Good evening, friends. So we are here again, and we will discuss the questions that we had put up for, especially the undergraduates. And I must begin by saying that I'm truly impressed by some of the answers coming through. Rishabh's answers are very apt on the dot. Keep it up. Now, a couple of more people have tried answering, including one from Sanket. It's a beautifully answered question, but there are few lacunae which we'll cover up. And don't be intimidated by a couple of interns who have all been my students, and you have all included them in the group. They've been taught by me in their clinics. So there'll be few things that'll come through, but don't bother about it. You answer your way. And I don't think you should ever be concerned as to, I mean, these interns are also undergraduate students as far as I'm concerned, but naturally they've got an advantage of a year of learning surgery from me, and otherwise also learning surgery and reading. So there can be some bit of, I can understand some answering by Naveen especially is pretty good, although it can get better. At places he's wrong also. So mostly he's done well. Most of you have done well. I'm pretty happy the way it has gone so far, and I hope you're enjoying it as much as we are enjoying it. And a lot of effort is involved in putting them together, and the credit goes to Sukriti for putting them all regularly on time for all of you. So make the most of it while it is happening. Now, the first case that we would discuss is the one where we had this 30-year-old gentleman, a 30-year gentleman, where we did not give you much of a history because that was more of a spotter. And the first answer that I got was from Rishabh, and I think it came within 10 minutes. So shows that somebody has been in the clinics regularly. Now, what did I show there? There was a transillumination test being done, and it was specially pointed that testes are separately palpable. That was a good enough hint, actually, if you really look at it. How do you differentiate scrotal swelling from an inguinal slash inguinoscrotal swelling? Well, first of all, when I'm saying always, I mean it. Always examine any patient always examine any patient with an inguinal swelling or any hernia anywhere in the body. I mean, abdominal hernias also can be ventral hernias. Standing first. This could well become a reason for somebody passing and not passing in an exam. It's taken so seriously because this becomes the basis of an understanding of whether it is a scrotal or an inguinal swelling. Now, a swelling that is confined to the inguinal region, the cord coming down here, testis being here too. Now, this is the swelling. If it is confined to the inguinal region and the person is standing, naturally you cannot get above. You can't get above the swelling naturally because it is coming from above. In standing position, it fills from above. This explains this and this explains this. Number 3, you can feel the testis or palpate it separately. Naturally, then there are, if it is a hernia, you have various other tests. You can do a cuff impulse. So you will see the impulse in the inguinal region. So broadly, this is why we should examine them in a standing position. Now, if you are, just to indicate a few things, now if the swelling descends down further, you cannot even feel the cord separately. So, first of all, examine them in a standing position. It will fill from above. You can't get above the swelling. You can feel the testis and also cord. You cannot feel the cord separately, but you can feel the testis separately. You can palpate it or see it separately. And especially for swellings like hernia, inguinal hernia, you can also look for the cuff impulse. But you can have varicocele, you can have some lymphocele, other swellings which are going down to the inguinal from inguinal region to inguinal scrotal region. So this can be one way to look at it. So if I was to say conversely, therefore, a scrotal swelling, you can get above naturally because it is testis is here. Most swelling will have something to do with the testis. So this is the testis, and you can easily get above. Suppose this is tunica vaginalis, which is full of fluid, hydrocele. You can get above it. You can feel the cord separately. Fills from below up. But the important thing is you can feel the cord separately. You can feel the testis separately. Now this itself becomes a reason, especially this, to examine this patient in a standing position, and once you find these features, I'm repeating, you can get above the swelling, it fills from below, can feel the cord separately, you can feel the testis separately. The only exception is based on the understanding of the development of testis and tunica. And that is ancestor hydrocele of cord. I'll explain to you what it is actually. Now when the testis is developing, it drags along with it. It's pulled by gubernaculum, but it keeps pushing the peritoneal fold along because it is coming from retroperitoneum. And then it comes down. This is the deep ring, or the only ring in an infant, because you don't have an inguinal canal in infants, so you don't have a proper canal. You'll have only one ring. Now pay attention here. So what does it actually do? This is the testis, and you have the fold of peritoneum that comes along, and we call it processus vaginalis. Easy to understand, and what is pulling it is gubernaculum. So this is when, if it goes in the normal direction, it will get down into the. Now if it goes in the normal channel, it reaches the scrotum and it is still covered by processus vaginalis, which is continuous. Then it starts obliterating here. Normally what will happen? Just a part, this side. The testis is here. So the whole process vaginalis was here, continuous. You can see that. Then it obliterates around it, obliterates here, right up to the deep ring. That's how cord tunica vaginalis will develop. This is testis. All right, just to simplify it for you. This is what should happen normally. This is a normal scenario. So you have tunica vaginalis, and that is peritoneum. So this is normal. But if it doesn't happen, various things can be found. That is, I'll give you various scenarios. It remains patent. Right? So it has remained patent. It's communicating with the peritoneal cavity. A lot of people call it congenital hydrocele, but the correct terminologies, I mean, when you hear of this, don't just uh, get confused. When they say congenital hydrocele, they're talking about basically what we call as triple PV, which is persistent, patent, processus, vaginalis. Now, depending upon the content, it can be a hydrocele, it can even be a hernia, which earlier we used to call it congenital hydrocele, congenital hernia. So if somebody was to ask you what is the management of congenital hydrocele, some of you get this question in the exam. For both, the answer is herniatomy. Because it is here that you need to block it, that's it. While it sounds absurd, because therefore the right term is, the first one I'm writing is triple P, we, remember that. Common mistake, and your books won't generally be talking all this. So pay attention. Treatment is herniatomy. So what is the treatment of congenital hydrocele? Herniatomy. What's the treatment of congenital hernia? Herniatomy. Now, how do you clinically differentiate the two? How do you differentiate between congenital hydrocele and congenital hernia? Promptly you will reply, which we have not asked. You will all jump and reply, transillumination, which you are seeing in this picture also, right? So you do transillumination to differentiate between congenital hydrocele, congenital hernia, and that will be a wrong answer. Do you know why? That even hernias, reason is hernias also. I mean, the bowel is so thin and it has got fluid in it. They are also transluminant. So transillumination would be a false test in a congenital hydrocele, or what we should call now patent persistent processus vaginalis. Now comes the how do you therefore differentiate? You do what is called the inverted ink pot sign. What is that? I don't know whether you see those ink pots anymore. They used to be like this in the past, if you see them in some archives anymore. They're full of liquid and the other one is full of sand. They used to have a narrow opening only. This is sand. If you invert it, that is, you put it upside down, this will empty faster. You've seen those hourglass uh, kept these days essentially for demonstration purposes only. The liquid will take longer. So what do we do? Longer. I just wanted to show that. It will come one drop at a time. The sand will just pour out faster. So what do we do? What is this inverted ink pot sign? If you lift up the scrotum, if it empties faster, it's a hernia. That is, there are contents which are solid. If it is slower, it is water. So, hydrocele. I hope you can read what I write, because I can't really make handwriting change. Most of my students understand it. I'm writing it again. So that's inverted ink pot sign, and one situation handle. This was that situation that I was referring to: persistent patent processes vaginalis or triple PV. Right? The next situation, therefore, I thought I'll take a detour and finish it all for you so that you can understand in continuation only, because one understands in relation to each other. Now, the other option is, it is patent till here and you have fluid here too. So that is looking like funnel. So we call it funicular hydrocele. You can mention it if you're asked. Rare scenarios. Third is, it is obliterated at the deep ring but patent right across up to the superficial ring. Do you know what we call it? This is the cord inguinal region. Infantile. It's a scrotal swelling which is extending up to the superficial inguinal ring, so not up to deep ring. This was up to the deep ring. That's the deep ring. That is triple PV. And then in between you have the funicular type, which looks like you can have sac right till here and here. And then you have an infantile hydrocele and one more variety. Therefore, it can remain like this. This is the testis. This is the tunica vaginalis. And somewhere in the middle, a part remains patent and rest is fine. Now, this will be the encysted hydrocele of the cord. Which is kind of a paradox. One can get above, testis can be felt separately, and cord also can be felt separately. And of course, fluid anywhere, translumination would be positive. When doing translumination, always throw the light from the side. That's and always fix the swelling. So in this case, you can feel the testis is separate. And sometimes you also have epidermal cyst, which can be almost also on the same line. Now, translumination would be positive. Classically, the case that you have seen. Clear? Now, so to sum it up, the only swelling that is scrotal but testis is separately felt. Encysted hydrocele of cord. I'll add only transilluminant swelling. That is one, it is scrotal. It has all the features. You can get above it, you can feel the testis separately, right? That's the testis being separately felt. And that is the cyst. So classically, a scrotal swelling, but with features which are slightly different. So paradoxically, that is what it is. Another such swelling is epididymal cyst, as I mentioned, but there it's too close for comfort to testis. So when you're doing transillumination, always fix the swelling, throw the light from either side, not from above. Always fix. So if I have to do transillumination, what is necessary? We'll probably share some video of how correctly you should do. When you're doing transillumination, the first thing is fix the swelling. Then light from sides, and it's an inspectory finding. That's what this case was. So this was a case of encysted hydrocele of cord. Perfectly fine to do clinical. You can rarely also get, I'm just trying to make it easier for you so that you don't run into people who talk about some strange cases. It can also be a lymphocele, but these are not common. So important, lesser even. So these are all scrotal swellings which you can actually sum up. So I'm starting with, say, encysted hydrocele of cord, which is the most common one, then the epididymal cyst and also spermatocele, etc. That's just to add to the list, right? And if you have varicocele which is coming down, then you do what is called as a bow sign is tested. When you bow forward, the varicocele would reduce because of the the drainage of the veins into the abdominal cavity. We'll discuss varicocele separately, but this was important to understand. So it's a clinical diagnosis. You don't need too many investigations, but if you do not ultrasound anywhere is right, because I have taught you last time also, ultrasound is an extension of clinical examination. So we will have an ultrasound, that is to rule out some other problems. He is a young man and may not be even subjected to any therapy. The treatment may not be required if asymptomatic. And usually what is their symptom? They can feel the swelling, so that is one reason why they come. And the other is there can be a dragging sensation if it is if it is increasing in size. So what will we do? It's like any other hydrocele. We'll just open it up, get the fluid out, and don't use terms like jabule or there would be at least 15 names that you would have to remember. So best answer all the time is eversion of sac in all cases. In a primary vaginal hydrocele also it will be right. Now what would be a primary vaginal hydrocele? I'll just complete the list, which is, so I'll write it again. This is the first one. The sac remaining patent, write down triple P V or congenital hydrocele or congenital hernia. The next is funicular, and here we do the inverted ink pot sign. I think I already explained it. test. Okay. Third is you may have everything fine. This is the deep ring. Deep ring is here, and you have it in the middle that some part remains. This is testis. Here, that's tunica vaginalis, and that's the encysted hydrocele of the cord. And finally, everything is fine, everything is okay. This is the testis, and this is where the fluid collects. That's why we call it the vaginal hydrocele. Vaginal hydrocele can be primary or secondary. How does it actually develop? There are two surfaces that I would want you to remember. One is a surface that secretes. I'll mark it with red. And the other is a surface that absorbs. So this produces fluid which we need for protective buffering action on the testis. And so that there is no excess of this fluid, the absorptive surface takes care of it, absorbs it. So what can be the pathology? Increased production or secretion and reduced absorption, or both. So when we know the cause, we call it secondary. And for you it is easy to remember if you take as tumor, tuberculosis, trauma, all T's. But they can be infections, which can be bacterial. They can even be parasites, that is filariasis. So bacterial, filarial, etc. I'm not getting into the depth of it. It can even be viral, say in mumps. It can even be spirochetal syphilis. A spirochete, right? And when you don't have a cause, conventionally we call it as primary. Although it will have a cause, and a lot of people feel that even here there is a filarial element, but you cannot establish it. So that's primary and secondary, and the diagnosis is based on clinical features as I have described. Clinically, it will be a scrotal swelling. What is a scrotal swelling? Swelling that is confined to the scrotum. You can get above the swelling. You can feel the cord separately. And importantly, you cannot feel the testis separately. Diagnosis is mostly clinical, but sometimes, say, if it occurs in 30s and it's a rapid increase and you're suspecting a tumor, then you need to do an ultrasound. We'll discuss this separately when talk of testicular tumor. And it will allow you to know if there is any change in the echo texture, etc. And then you can proceed further. So it would vary what you need to do, but most of the time that's a treatment. And when it is primary vaginal hydrocele, the most common one that you're going to get, the answer is you confirm by transillumination, it is a scrotal swelling, and manage it by eversion of sac. For those who want to hear more about it, there is a Lord's plication, which is done only for smaller hydroceles. And what do we do there? Rest is very simple. I mean, I think I was explaining it here when I got into this. Now, this produces, this absorbs. And if you really want to have that's the testis, complete cure, then we evert it. Eversion takes the two away from each other, two surfaces, that is secretory and absorptive. They get separated from each other. It's like what was done to Jarasandh. You cut through this and you evert it. When you evert it, they start, the fluid gets, when it is produced, it gets drained by the lymphatic. So that is how you get a cure. So when you're talking about Lord's plication or Jabola's procedure, they're basically just relative terms. Essentially, it's eversion of sac. In a Lord's plication, you just keep cutting through the sac. Finally, you push the testis out. And when the testis is out like this, the sac is like this. We take a running continuous suture right up to here, hold it, and we do it all around. So when you tie it, it becomes like a flower. Achieves the same thing, but it's generally done in very small hydroceles. The best answer is open it and evert. So that will take care of it. I mean, that's about this case. So it is the case of encysted hydrocele of cord for the reasons I just described. It's a scrotal swelling, the only one which is transluminant, classical transluminant swelling where the testis can be felt separately. And that's exactly what I think Rishabh answered in 5 minutes. I think that was a very good answer. Quickly, just stick to the basics. Don't try to complicate. Some of the question answers and the coming answers I would discuss that they've been made complicated unnecessarily.